Well, good evening, everyone. I want to introduce myself. My name is Greg McAteer. My pronouns are he and his, and I'm the manager of community relations and engagement for the All of Us research program here in Central Arizona. We are so excited to be hosting this very important webinar tonight, our fourth webinar in our ongoing series, and very thrilled to be hosting this discussion during Pride Month to be discussing myths, stigmas, and barriers in LGBTQ plus health. We have a few excellent panelists with us tonight who will be covering and discussing those crucial issues in LGBTQ plus health. I want to kick off the evening by introducing Michael Galbraith, who is a member of the engagement team here in Arizona, focusing on LGBTQ plus issues within the Valley. Mike will be discussing stigmas and myths within the community and will explain the importance of correcting those false stigmas. Thanks so much, Mike. Please take it away.
Good evening, everyone. So we're asking the question tonight, why correcting LGBTQ plus health stigmas matters. Members of the LGBT plus community encompass all races and ethnicities, religions, and social classes. Obviously, these groups are all really important to all of us because that's what we focus on. So research indicates that LGBTQ plus folks face health disparities linked to social stigma, discrimination, and denial of their civil and human rights. Discrimination is associated with a higher prevalence of mental health disorders, substance abuse, and suicide. So researching these are obviously quite important. You can go ahead and go to the next slide, Greg. So harmful, false, historic beliefs and stigmas. This is a falsehood that's told time and time again that homosexuality is a mental or sexual disorder. A lot of it stems from the 1952 DSM new publishing. So it listed homosexuality as a sociopathic personality disorder. This false belief was used to legally discriminate against the LGBTQ plus community. It wasn't until December 1973 that the American Psychiatric Association Board of Directors voted to remove homosexuality as a diagnosis from the DSM. Homosexuality can't be cured. This is probably not needed to be stated in 2022. It's not really something people still believe. But after that publication in 1952 of the DSM, psychiatrists and psychologists attempted various cures for homosexuality. There's a long list of them on screen. I'm not going to read every one of them. But these methods obviously proved unsuccessful and generally dangerous to the people that they were used on. Next slide, please. So gender affirming surgery or hormone therapy is never medically necessary. This is probably a newer myth, a newer thing that people tell based on the kind of rise of needing transgender rights in healthcare and stuff like that. Gender dysphoria is a serious discomfort with one's gender identity or gender role, for which the sex is assigned and could be therapeutic. A formal diagnosis of gender dysphoria was introduced in the DSM-3, further legitimizing it as a psychiatric condition and providing guidance for treatment. Today, some insurance companies cover gender-affirming surgeries when deemed medically necessary.
Thank you, Mike, so much for that. Really appreciate it. Some really crucial statements. We wanted to kick the webinar off with that just to really set the tone. I'd like to introduce our next speaker. Jimmy Thomason will be speaking tonight about HIV basics. Jimmy is the executive director of the Aunt Rita's Foundation, an organization dedicated to the elimination of and suffering from HIV and AIDS. Jimmy's previous experience includes work as the Vice President of Global Human Resources at Bank of America, in Human Resources for Hilton Hotels, and assistant to the CEO at the Make-A-Wish Foundation of Arizona. Throughout his career, Jimmy has served in multiple advocacy roles for the LGBTQ plus community and has earned awards for his volunteer work from organizations like Southwest Center, 1 in 10, Phoenix Pride, Aunt Rita's Foundation, and more. Thank you so much, Jimmy, for speaking about this. I know this topic is imperative and looking forward to learning more.
Thank you, Greg. And I probably should have just done the same thing Dr. Sokan did and said not to introduce me because honestly, the fact is, you can go to the next slide. That's all my information. So I'll just introduce myself a little bit though about because all that is boring. The reality is I tested positive in 2005. I've been positive for 17 years. I was 22 years old when I tested positive, and the reality of that is I'm an in-betweener is what I call myself. I didn't experience the horrible times in the 80s and 90s, hardly at all, but I didn't also experience what we're going through now, which is the incredible research and development that has happened to make it so that you can be undetectable from HIV within 3 weeks to 2 months. So you can move on to the next slide and I'll talk through it. And the biggest thing to talk about first, I'm going to show you a lot of facts very quickly, but I also want to just talk about the most important piece, which is what stigma is. And so I pulled up the definition, as a professor might do, and said it involves, negative attitudes or discrimination against someone based on a distinguishing characteristic such as mental health, health condition, or disability. Here's what I believe stigma is. It's fear. It's fear of the unknown, of fear of, I don't know somebody who has had this, I haven't experienced that in life. And I don't know if any of you know the researcher Brene Brown. She's a behavioral researcher, but she believes that anything can be taken over by empathy. And so we're all built with our own lens, and with that lens, we learn sort of our own experience. And empathy is not so much walking in somebody else's shoes as much as just asking somebody what it is like to walk in their shoes, and then to experience that and believe them. So what you see in front of you is what HIV is in Arizona right now versus what it was in 1985. And so these are the deaths that happened. And you see, I like to call it the electric slide when I talk to my donors, because it's slide to the right. And I love that because it means that people were dying in their 20s and 30s in 1985 when it comes to HIV. And now we are living long, successful, healthy, full lives. And I'll tell you, I have substance use in my past, and I'll cover that a little bit further down, what importance substance use has with HIV, but also, and the LGBTQ population specifically. But, truly, the fact that now we're moving into living full, long, healthy lives, it's, we're going from a very difficult time to now we have all the tools available in our tool shed to control this infection, which is HIV, and then also just eliminate it altogether. So if you could go to the next slide. The most important factor here regarding HIV specifically, and this is focused on the LGBTQ population, and I recognize that, but the most important fact is to focus also on the equity of HIV and health in general. So we can look at a pie chart in Arizona, and the Black population is very small as far as HIV infections. But if you look at it from a per 100,000 by race, we're looking at the Black population is more than double any other population. And the white population is actually the smallest now, which surprises a lot of folks. And we'll talk about that in another slide. But this is such an important piece to look at because the fact is, we consider HIV to be this. Often when I talk to donors, when I talk to specialists who are not familiar with HIV, they understand this to be a white gay men's disease. And so it's not so much that. And the reason that they understand that is because white gay men often have the loudest voice in this population. And so what ends up happening is that that's what's recognized. And so that voice is heard loudest. And what we're trying to do at Aunt Rita's Foundation, and again, I'm the executive director of Aunt Rita's Foundation, and our role is that we fund millions of dollars to organizations throughout Arizona for HIV programs, but also we have programming ourselves that help with any gap filling that we need to do with the older population and others. But we can move to the next slide. And I want to talk about what's in between these lines. Again, it's about health equity is what we're talking about, stigma specifically. So stigma involves the fact, again, of fear and equity. That's really, truly what it involves. And so in the 80s, health equity was really more focused on the white population. So you're going to see a lot higher numbers just based specifically on that, on gay white men who were able to go to medical facilities and get tested and find out their health, and then also, get the treatment that they needed into the 90s when treatment started. But there was so much fear and stigma along these lines that it was so difficult for the first 20 years to even get anybody into testing and into the right treatments as treatments began in the late 90s. So the incidence cases are really a little bit skewed at the beginning, and then you'll see that they sort of balance out at the end, but still the Latinx population, of course, is higher in Arizona than in other states, but also in the Black and Latinx population, you'll see the stigma is actually focused on a few factors. One is that we have the religious factor built into the cultural piece. So Aunt Rita's Foundation actually started a diversity and cultural council that is focusing on the religious aspect as well as just the cultural piece of you either don't talk about it inside your home or you don't talk about it outside your home at all. And both of those things affect the testing of HIV and then also the treatment in general. So the testing, of course, is the first piece of finding out if you do have HIV, and then you can move forward with what the next steps will be. So you can move on to the next slide. So risk reduction. And you can go through, again, as I told you, Greg, all those dots. But the risk reduction options, avoid unprotected sex. I think most of us know all these: use protection, limit multiple partners, avoid drug and alcohol use. And I'll tell you, in my, decades career of being a professional, but also in my 40 years of life, and also in my 17 years of being HIV positive, I have probably made mistakes in the majority of these. And I think that's the most important piece to talk about, is the fact that, if you're going to be discussing anything with somebody, it's that you need to have a real conversation. There needs to be empathy, there needs to be compassion. And so whoever you speak with, their lens is going to be different from yours. And so even if you haven't experienced these, others may. And so that's honestly, when you get down to it, the point of this entire presentation is that your perspective is going to be different than others potentially. Every person's life is different. So all of the risk reduction here, yes, we encourage it, of course, and yes, it is important, and that's how we stop HIV, but also we need to understand that that isn't always what happens. So you can keep scrolling down there, down to, honestly, the most two important points at the bottom, the next two, which are PrEP and PEP, which we'll talk about. So ending the HIV epidemic. Our former president actually announced at the State of the Union in 2019 that there's a 10-year goal. That was very encouraging to end HIV. And during that time, it was identified that Maricopa County, our county, the one I live in at least, is one of 48 that has the highest incidence rates of HIV in the United States. And so that shows that we really need to focus here in Arizona. The goal is to reduce HIV by 75% in 5 years and at least 90% reduction in 10 years. Now, again, it's about reading between the lines of all these graphs and all the things that I've just shown you and understanding the cultural piece and the LGBTQ piece and the fact that there is so much shame involved in being LGBTQ plus and having sex with men. So, you know, a big piece of the stigma is, again, really the G and the B is a huge piece. And then, of course, the transgender community is highly affected by HIV. And the reason for that is because, you know, it's about silence. We don't talk about it. And so men who have sex with men, MSM, is what we use instead of gay or bi or transgender. And because, you know, sometimes there are times when somebody considers themselves completely straight, but they also at times will experience a sexual encounter with a male. And so it's not about judgment. It's not about passing judgment. It's eliminating that stigma and just saying that, you know, if you are a male who had sex with a male, there is a potential risk there. And so, fortunately, the United States and the CDC has agreed with that and is moving forward with that. But also narrowing it down to the next slide is the Phoenix Fast Track Cities Initiative. It was agreed upon by the Phoenix that we need to become a fast track city. We were actually one of the first, along with the city of Paris, France, to become a fast track city. The goal of that is 90, 90, 90, 0. So 90% of people living with HIV know their HIV status. So that right now is at about 70 to 75%. And so that is scary, right? Because that means that the rest of those individuals don't know their status, which means they are potentially passing on that infection and expanding it even further, or at least not stopping it where it is. Again, we have every tool in the toolbox to stop HIV in its tracks today. So the next one is 90% of those who are living with HIV, once they test positive, are on antiretroviral treatment. What many people don't know is that we have so many, even 1 pill a day regimens. We have multiple options for that. When I tested positive in 2005, I was taking 5 giant horse pills a day, and that was after I had double pneumonia 2 years later, because they wouldn't put you on medications because they didn't know how toxic they were. And so, you know, now we're in a place where we have rapid start, which means as soon as you test positive, we give you a bottle of pills, and you take 1 a day, and they're very small, and you're negative within, again, 3 weeks to 2 months. So go ahead to the next slide. I'm sorry, to the next piece. And the other 90 is those 90% of people living with HIV on that treatment are achieving viral suppression. And that means that they are not able to pass on HIV to another human being. As hard as they could try, if they're adherent to their medication, there is no way to pass on HIV to another individual. I don't know of any other virus, honestly, that can be suppressed the way HIV can with these treatments. And we're talking, you know, 39 different types of treatments that will virally suppress an individual. So in COVID, you know, there are multiple different variations, and that's happened. HIV is 40 plus years old. And so that those variations have happened because of sort of ignorance or not paying attention to this disease as much as it should have. And we've got that momentum going, but getting that viral suppression is what's going to limit that. So, and then of course, zero stigma. So Phoenix has committed, the city of Phoenix has committed hundreds of thousands of dollars to focus on eliminating stigma and eliminating HIV altogether. So you can go the next, and that's, again, you can go through those bullet points, but really, again, it's getting tested, using protection, avoid sharing needles, which is a huge piece of this. Open conversations with your partner. Have those conversations. Honestly, everyone just, again, stigma to me is not so much about judgment, it's about fear. It's about fear of the unknown. And so open conversations with anyone is so important. PrEP and PEP, which we'll talk about in a second, are really going to be the vehicles for us to avoid HIV and end it altogether. So harm reduction, fortunately, we are so lucky. And by lucky, I mean we tried for many, many years, 3 to 4 years, to legalize syringe access in Arizona. This was a huge step for us in 2021 to get approved. Governor Doug Ducey signed it into law that we now have syringe service programs. We actually had them before, and Aunt Rita's funded them prior to them being legal. But now, so prior to 2021, if you handed somebody a clean needle, you were actually breaking the law. So people were sharing needles. People were, and that was an easy way to easily get infected if you were in a position where you were using substances and could not get a clean needle. And so now that is now legal as of last year. The next piece, though, is the most exciting and the most recent. And that's the next slide, which is general consent. So general consent, as of last month, less than a month ago, it was signed into law. It was passed almost unanimously by the House, completely unanimously by the state Senate in Arizona, and signed into law on May 25th, that in the 80s, 90s, early 2000s, if you wanted to get an HIV test, you were either just a number, you would put your number in, because if insurance companies or your employer or anybody found out that you were HIV positive, you were done. They could cancel your insurance, they could end your employment. And so now there are federal protections against all of that with the Affordable Care Act. Now there's, you can, having previous conditions is not an effect to the issue at this point for getting insurance. So now we're in a place where it's recognized that we can now test as a general consent. You don't need to request separately for an HIV test as of 91 days after the Senate closes, which it hasn't yet. But at that point, probably in October, November, it will now be placed where your cholesterol will be checked, your platelets will be checked, and your HIV will also be checked, any HIV antibodies. And that's just general, goodwill to just check one thing at a time. And we will be, I believe we'll be getting additional diagnoses, but we'll also be eliminating, because every time we find an HIV diagnosis of somebody that didn't think they were going to get tested or didn't need to get tested, you still can opt out. But if you get tested and test positive, you're essentially eliminating $6 million, 6 individuals from testing positive, and that stigma goes away as well. So go ahead to the next slide. So PrEP is really a big piece of what's going to eliminate the stigma. PrEP, actually, if you take it, there's Descovy, which is a very small pill, and then also Truvada, which is now generic, and so it costs less than $30 a month. But and there are 9 different kinds, but the reality is it's all free. PrEP costs nothing, and you actually can take it every single day. If you are somebody who is at risk in any way, the government has agreed to pay fully, and the pharmaceutical companies to completely cover a monthly regimen. So it's a daily dose of PrEP, pre-exposure prophylaxis. It's either Descovy or Truvada, and it's 99.6% effective in preventing HIV transmission. So if you're taking that every single day, there is almost zero possibility that you can get HIV. I'm sorry. Again, no matter how hard you try, if you're adherent to this medication, you cannot take it, or you cannot get HIV. There's also a new treatment that is an injection that's every 2 months that you can take if you're not used to taking pills on every day, if you're not as old as me and taking high blood pressure medication, cholesterol medication, and all that. You can actually just take an injection every 2 months and have PrEP. The next piece also is really important, especially for pregnant women, but also anybody who's been exposed unexpectedly. So the next slide is PEP. It's actually the exact same pill, but you take that within 72 hours of any exposure. This happens a lot. So we work with Phoenix Children's Hospital. They experience, unfortunately, younger individuals who have had sexual assaults, others who have, and then of course there are individuals who have had sexual experience with somebody who did not tell them that they were HIV positive previously. If you take that within 72 hours and you do that 28-day regimen, that actually reduces the risk as well. So there is a PEP hotline number on there, but there are actually many, many resources. And one of those is hivaz.org. That's the #1 resource that Aunt Rita's Foundation provides in coalition with ADHS to provide every resource possible for PrEP, PEP, any information you need. So we can move on to the next slide. And this is probably the most important as far as stigma goes, is that once you are virally suppressed, once you're adherent to your medication and you are completely undetectable. So for me, what that meant is in 2005, I tested positive. Again, they didn't give you medications until you were very sick. So I had double pneumonia and ended up in the hospital in 2007, and they finally said, okay, we'll give you the medications, because they didn't know how toxic they were at the time. We're so far advanced now that we're giving you pills right away. We're giving you the shot right away if that's the preferred treatment. And you can be virally suppressed. It says at the bottom 1 to 6 months. That's the official CDC statement. But in our research in the city of Phoenix, with the ad hoc committee here, is that within 3 weeks to 2 months, you can be virally suppressed, which that means you cannot pass this on to anybody else. So you can move on to the next, which is HIV testing. There are multiple options available. The best option for many who especially experience stigma is gettestedaz.org. And that involves a home test kit for HIV that you can get for free. If you're an Arizona resident or if you have an Arizona address, you can get an HIV test kit. It's a box that has easy instructions. It's an oral swab. There's no blood involved. And then you can find out if you're positive, and there are resources involved there that we can provide to you. There are also the rapid tests that we often do at festivals and fairs, and then there's the general blood draw, which also we can provide a voucher for free. I'm trying to speed through here because I could say so many more things, but I do want to talk about our initiatives at Aunt Rita's Foundation for 2022, and they're all focused more on the HIV positive community, all through the spectrum, which has experienced escapades. So half of the HIV positive population half is over 50 years old, and that's great news. Again, we saw in one of the original slides that now people are living much longer. People are living past 50 up through a full human normal life. And so we are now taking them out on a monthly basis and taking them to 3-course dinners for free and taking them, including Lyft rides, to Top Golf this month so that they can experience just some fun without the stigma and see that isolation and survivor's guilt, the two primary issues, are no longer an issue for them if they desire to take us up on our offer. The next piece is youth retreat. We're going to have a youth retreat. There are still HIV positive youth. Between 14 and 24, the 20 to 25 year range is actually one of the top age ranges, and it's basically as far as infection goes, and that's primarily because of not enough education, which I'm glad that I had the opportunity to speak today. I'm thankful to all of us program for being able to do that. But this youth retreat will cover from 14 to 24-year-olds. So these 14-year-olds who potentially have been positive all their life, there are 82 individuals under 18 in Arizona who have HIV. And then those who have tested positive later in their early 20s, they get to experience each other in different ways. The newly diagnosed who are in their 20s, those who have been HIV positive their whole lives, they get to share what it's like to disclose to somebody, or what it's like to have take a pill regimen. So it's going to be a very exciting retreat. It's going to be in November. The last one we had in 2016, it was one of the most meaningful weekends of my life. And the next one is the Cultural and Diversity Council, which we've now changed to the Health, Equity, and Cultural Council. And the reason is because we're talking about health, equity, and cultural issues throughout the HIV community. That's the hottest topic right now, and I think it's the biggest focus for me once I started this role a year and a half ago. I've been involved with the organization for 15 years, but seeing how much the community is affected from a cultural standpoint, we're creating a council that will focus on how to take care of the newly diagnosed by showing people, individuals that look like themselves, that have their shared experiences, and then also asking those individuals, all right, how do we stop it? So, the next page is really just resources that you can definitely get. Again, auntritas.org. You can get my information from that if you'd like, and also all of our events and programs. And HIVAZ.org will give you resources throughout the state. And gettestedaz.org, again, will provide you a test anytime you'd like it, and also an at-home test or a voucher. And we're actually expanding to STI vouchers as well. So thank you so much. That's what I have. I usually have an hour and a half, so I hope I didn't throw too much at you, but I'm happy to answer any questions, or you're welcome to reach out to me as well.
Thank you so much, Jimmy, for the in-depth look at this. This is really incredible. I'm going to quickly throw one question at you from someone while we have you, if that works for you. The question is, I'm an alum of the MPH program and did my internship with the State Office of HIV Prevention back in 1999-2000. What were the critical tipping points that allowed new laws like needle exchanges to pass?
So there's, well, I'll be honest with you. I'll tell you like a 1-minute story as best I can. Well, essentially, one of the biggest pieces is that Aunt Rita's, the universe provided Aunt Rita's with an incredible lobbyist who actually tested positive in prison. He is a older white gay Republican, or I'm sorry, a white straight Republican lobbyist who tested positive when he was in prison due to drug use, and ended up, it was a false positive. He was thrown in solitary confinement for a month, completely alone, then tested negative. And after that, he sort of fell in love with Aunt Rita's and the goal to make sure everybody feels safe and secure. And so he joined our squad at Aunt Rita's a few years ago, and he has worked very hard on that Republican side to explain to people the importance of getting this done. Also, just changing hearts and minds in general, and really the pragmatic piece. Again, I mentioned there are 6 individuals equals $6 million of treatment, and so if you're testing individuals and getting the needle exchanges involved, that's saving money. So unfortunately, we have to look at it from both angles. For the pragmatic piece is that there's the health piece, there's the mental health piece, and then there's the money piece. And all of those are affected in this.
Perfect. Thank you so much, Jimmy. I always say lifelong learning, is the key to success in so many ways. So making sure that we're educating ourselves on this topic because it's changing so quickly, and you've seen that firsthand. So appreciate it, and thank you so much for your thoughts.
Thank you.
So I have the privilege of introducing our next speaker, Dr. Sokan, who will be discussing barriers to healthcare access in the LGBTQ+ community. Dr. Sokan made sure that I was not going to introduce her because there's too much to say, and she says she wants to get right off the bat and start talking. So I'm going to turn it right over to you, Dr. Sokan. Thank you so much.
Hello, everyone. I'm really excited to be here. And it was awesome to listen to both Mr. Galbraith and Mr. Thomason. And so you've already heard about myths and stigmas, and you've heard about HIV. And I'm so excited that we've actually moved the needle and a lot has been done there, but we still have more to do. Next slide, please. Next slide, please.
Are you seeing that, Dr. Sokan?
Okay, so yes, now I see it.
Great.
Okay, so, I was talking about the fact that we've come a long way with HIV, and that's a wonderful thing. But it's still important for us to consider the many challenges that are faced by the LGBTQ plus community. And some of this you've already heard in the discussion about stigma as well as about myths. So one of the biggest things that creates the bedrock for all of the challenges that we see is the invisibility of this population. And that has consequences and comes up in so many different things. So for instance, in terms of health concerns, we already heard about HIV. And so people who are either living or aging with HIV, that becomes a concern and a challenge. How do we deal with this, right? And even though, like I said before, we heard from the last presenter, the sort of strides that we're making, we have examples of some new areas that we need to be focusing on. For instance, older adults, right, have now become one of the populations where we find an increase in HIV because a lot of them grew up during a time where they didn't have the sort of sex education that we have that flags unprotected sex and what happens and how you get HIV. And so we're now finding an increase in that population. There's work to be done. But going back to the invisibility issue, there are gaps in research. So LGBT populations are very underrepresented in research, no surprise there. We find gaps in services because the services are not culturally appropriate. And certainly there's a gap in terms of policies. And that's what happens when you have a population that's been rendered invisible by the cultural norms of the day. Health disparities is another big issue, right? And that flows from the history of discrimination and victimization and stigma. Other factors include things like the social context of lives lived, right? So if a social network is really important in terms of being protective, and you don't have that, then we have issues like isolation, et cetera, that become an issue. We also know that LGBTQ plus persons usually are more likely to have either poor access to health and other social and health services, or in some cases, lack access. So these things create all kinds of different challenges. And then, of course, we cannot forget just the consequences of the adverse experiences lived across the life course. And it doesn't matter how young or how old you are, we find consistently that there's a reluctance to engage in needed services across the life course, and especially in later life when we're looking at older members of the LGBTQ plus community, where there are certainly increased risks to health and a negative impact on overall health status. Next slide, please. It is important that we understand LGBTQ plus health. And indeed, it's really important that we understand that. And why is that important? For one, LGBTQ plus members of our community are exactly that. We're all entitled to live safe, healthy, and protected lives and to have quality of life. But when we look at LGBTQ plus communities, we have to understand the drivers of poor health. We also have to understand the drivers of outcomes that are positive in terms of healthcare encounters for this population. So when we're looking at the social determinants of care for LGBTQ plus populations, we have to think and remember that history of oppression and discrimination. And we keep coming back to that because you'll be amazed just how much of an influence that has on health status. So some of the things that we would be interested in looking at is legal discrimination. So remember I talked about the poor, the lack of access to healthcare. the inability to have health insurance would restrict access to healthcare. We find discrimination in employment, in housing, and even in terms of finding places in long-term care facilities, right? So these are really critical issues. We certainly need laws for protecting against bullying in school, because children who are bullied when they're young, we know that the trauma lasts longer than we would expect that to last, right? And affects health status. So the lack of social programs for LGBTQ youth, adults, and older adults, the shortage of healthcare providers, and that's a huge one, who are knowledgeable and culturally competent and willing to engage LGBTQ plus populations in meeting their healthcare needs. That history that we talked about, I think we went back, but we should be going forward. That's a previous slide. Next slide, please. Yes. So just as an exemplar, oops, it moved again.
You must have a little bit of a delay, Dr. Sokan, but let me know if this is the right slide. Factors affecting health outcomes.
One before.
One before.
Mm-hmm.
Okay, that should pop up for you in a sec.
Okay. Technology is wonderful when it works.
It sure is.
Right. Okay. So it's important. So we keep talking about healthcare challenges, but it's really important to sort of highlight some of the concerns that LGBTQ plus communities face. So we know that compared to heterosexual populations and other groups, so we know that there's a higher rate of disability. And we know that there are higher rates of health limiting behavior. So for instance, members of the LGBTQ plus community are more likely to engage in tobacco use, right, than mainstream populations. Now, there's a challenge there, right? It's not because one group is better than another, but think about what we do in public health in terms of interventions that help people understand about smoking and smoking cessation, right? If we put those interventions out there and we do not adapt them so that they're culturally acceptable and relevant to LGBTQ plus populations, then we're going to miss out on getting the message to them. So all of these things are really nuanced things that we should be thinking about. Certainly there's a greater risk of physical health problems as well as mental health problems. So think in terms of chronic conditions and multimorbidity and premature mortality. So people who die earlier than they should. Again, no surprise when you think about things like restricted access to health insurance and poor access to healthcare, and healthcare providers who really haven't sort of built any trust with the LGBTQ plus community, or are ignorant or unaware of their healthcare needs and so how to respond. Mental health issues, really huge. In the general population, we don't do nearly as good a job of addressing mental health. So just imagine the deficits that occur when we're looking at the LGBT community, especially when you consider just the lasting effects on mental health that emerge from that history of marginalization, of discrimination, and of prejudice. The one thing that's really important when we're talking about the LGBTQ plus community is to avoid the tendency to treat this group as one homogeneous group, because it isn't, right? And so even we talk about within group differences. So even within the LGBTQ plus community, we find variations in terms of what we would find, say, for instance, within the lesbian communities, whether we're talking about men who have sex with men, transgender. So even when we're looking at mental health conditions, some groups suffer more within that community than others. So it's really, really important for us to understand those health concerns. Or actually, let me take it one step back. It's really important to understand the definitions and the different subgroups that make up the LGBT plus community, and then to understand what the challenges might be for those individual subgroups. Next slide, please. So again, because it's important, let's talk about the factors that affect health outcomes. So we've talked about things that affect health status. and it's a slight nuance change, right? So we've talked about the fear of discrimination and stigma. So that the AARP did a couple of studies. One was in 2017 and another in 2019. And we consistently found that, that a high percentage of members of the LGBTQ plus community report that stigma. And that becomes a problem if that stigma occurs, if you encounter that stigma in healthcare, right? Because that's going to have a direct effect on the quality of care that you get, whether we like to accept or recognize that fact or not. Now, again, how do you get the sort of healthcare that you need, right? That's going to result in a positive outcome if you are unable to disclose your sexual identity or orientation to your healthcare provider. So that lack of openness to be able to bring your full self to the healthcare encounter becomes an issue that affects healthcare outcomes. A lot of LGBTQ persons delay seeking care because they do not want to encounter that stigma. There's a lack of trust in the healthcare encounter, all of these different reasons, right? So they delay seeking care. And another factor that affects LGBTQ plus communities that we might not think about is the issue of impoverished social networks. So if you take, for instance, older adults, right? We know that the older we get, the smaller our social networks become because friends die off, people move away, things happen to our family members. But when you look at members of the LGBTQ plus community, especially those who were ostracized by their families and who have had to live their lives outside of those traditional structures that create the social networks that we have and that we rely upon, you can see how that becomes a challenge. Because in later life, for instance, sticking with the older adult example, the chances of having a caregiver, right, who takes care of you or who's responsible for you or who you can be dependent upon, it becomes an issue. And that also affects quality of care. We talked before about the lack of competent and inclusive healthcare. That has to be really critical because you cannot, how do you provide care to a population that you either do not understand or cannot recognize the flags that should be triggers for what you should do. And the distrust of healthcare providers, trust is a real issue, right? How do you get through a healthcare encounter if you cannot be your true self and discuss the real challenges and issues that you have with your healthcare provider? And that one of those ARP studies that I talked about indicated that at least 40% of the persons interviewed disclosed that they really distrusted their healthcare provider. So these are things that we really need to work on if we want to improve health outcomes for this population. Next slide, please. Examples are always really great because they help illustrate the conversation, right? And add more color. So if you look at this slide, and again, this is from AARP, and AARP has really stepped up and done a good job of tracking issues that affect LGBTQ plus populations. And there are other resources. But I like this one because you can see that we have three sets of blocks, right? So we have three races, and ethnicity. So you've got the Black African American, you've got Latino, and you've got white. And then I want you to look at the different blocks. So we're looking at age, we're looking at race and ethnicity, we're looking at sexual orientation, and we're looking at gender and gender identity. And the question is, as you get older, right, how concerned are you that the quality of care, going back to health outcomes that you receive from healthcare professionals and staff will be adversely impacted based on all of these different things. Now, why is that important? So if you look at the African-American population, right? So you see that if you're African-American, you already have that 41% concern, about 41% of people have that concern that their healthcare encounter is going to be affected by their race. Right? Then you tag on to that the sexual orientation, 42% of them said that. And then gender identity. Now, why is that important? and you see similar pictures across the other two groups. Why is that important? We talk about the concept of multiple jeopardy, and that means that where you belong to a group that's marginalized on some element, right, then every other element that creates marginalization or discrimination just compounds the negative effects that you have. So just think about members of LGBTQ plus communities. They are of all the different races, right? So you could find someone who's LGBTQ and Latino, right? And so they're going to suffer two different interlocking trajectories of discrimination, and think about what that does to health status, right? And that becomes important as we go across. And when you add gender identity, and age, you then see three things in operation. So it's bad enough because we have challenges, for instance, using this example, that older adults face when they encounter the healthcare system, right? Then you lay on top of that being Black or being Latino, right? And then you lay on top of that sexual orientation and gender identity. It's really important for us to understand how these things become compounding factors, and it's really important for our healthcare providers to recognize how these things work together to impact health. Next slide, please. So hopefully by now you're sitting in your chair, you're pulling your hair out and you're saying, what can we do? We really need to do something. We can't just let this go away, right? And you would be right. And we need to think in terms of just the benefits. What's the return on the investment of addressing health disparities in the LGBTQ community? And there are quite a few. And they range from the altruistic, right? Which for me is a really good reason, i.e., every single member of our community deserves quality healthcare because they deserve to be able to live their best lives and quality of life, right? So quality of care, quality of life is something that we should all have. Now, if that doesn't work for you, we can go to the other end and say, well, think about healthcare costs, right? And what that does to our economy. So even if we're looking at just the Benjamins, right, it behooves us to think about ways to improve healthcare. Now, I'm hoping that the other things are really important, because think about the reductions in disease transmission and progression. That's certainly a plus, not just for members of the LGBTQ plus community, and that's really important, but for those of us who love them, and for those of us who are their neighbors and family members and live in community, right? Think about increased mental and physical well-being. I already talked about quality of life. That is critical, and that should be a human right that we, all of us, are entitled to and should protect for each other. I've talked about the reduced healthcare costs for those for whom the Benjamins are important, and certainly increased longevity, because every single person brings value to our community, right? And when we lose someone, regardless of what community they belong to, we lose valuable resources that we can use to improve the lot of everyone. Next slide, please. So, what's the call to action? What should we do, right? Because we can't just sit around and go, well, you know, we guess something's going to happen, or maybe somebody else is going to do something. No, we all have a responsibility. And that responsibility comes in a number of ways, right? We have responsibilities as members of this human, of the human race, right? To work with each other and to affirm each person's right to a quality life and to a life free of disease, and et cetera, right? But we also have the duty, if we are healthcare professionals, right, and providers of care, how do we ensure that we meet members of the LGBT community where they are and provide patient-centered care? We make a lot of noise about that in healthcare. We're always talking about patient-centered care. But what is patient-centered care? For LGBT people, patient-centered care must be person affirming care. And if it does not affirm the person, then there's no way that we can call it or should call it patient-centered care. So we need to recognize the growth in numbers of LGBTQ plus community. That's a big one, right? We need to recognize that this is a growing community and it's a viable community. We need to get our data right. and in so many different ways, not just about numbers, but about concerns. We need to identify and acknowledge those unique needs. We cannot treat everybody like everybody. There isn't a standard. And I talked about this before. LGBT community is not a homogeneous group. Within group differences exist, and we need to understand those definitions and how these groups are different. We certainly need to develop prevention and intervention strategies. Sometimes people say, well, we don't have enough money to do that, right? We don't have to reinvent the wheel. What we really do need to do, though, is look at a lot of the strategies, the prevention strategies and interventions that we already have, and figure out how to adapt those so that they are culturally appropriate and culturally relevant for members of the LGBTQ community. Whatever we do that focus on health has to be critical. We need to address issues that limit, restrict, or remove access for members of the LGBTQ population. We need to think in terms of how we make our healthcare providers better able to serve this population. And we also need to think about structures and policies and practices, because it is too much to expect this to be some sort of Russian roulette, where as a member of the LGBTQ community, the quality of care that I get is dependent on the healthcare provider that I meet. That's too much, right? What we need is for healthcare organizations to create processes and to put structures in place and have policies that ensure that regardless of the healthcare provider that I come into contact with, that I get the patient-centered, person-affirming care that it's due to me as a member of the LGBTQ plus community. The only way we can make any change is to optimize the healthcare encounter. And for us to do that, we need to be working on all of these things. Next slide, please. So I love to talk about this because it's two things, right? Who's in the encounter, right? So we have the healthcare providers, and then we have the healthcare recipients. So for healthcare providers, it really is not rocket science, right? A lot of the things that need to be done do not require reinventing the wheel or doing anything that's onerous or burdensome. But it does require for us to be informed, to be aware, and to be intentional, right? So think about signals, signs, and symbols. And what do I mean by that, right? You walk into the doctor's office, right? Or to the healthcare, to your healthcare organization. Have your signs show, right? Or be welcoming. Have signs and symbols that allow members of the LGBTQ community to know that you recognize that they are here in your community and that you are prepared to provide that care. And so in this way, you send the message that we will affirm your reality and your personhood. We will be inclusive and we will be non-judgmental. And simple things like forms, right? So the gender is one of those things, that we get all the time, and you get two options, male, female. It's binary, right? A simple third category that says other would help that, right? So the people can identify or use whichever terms they want. Asking people about the pronouns that they use, right? So in our information collecting mechanisms, ask people about their names, ask them about how they would prefer to be identified. Just really simple things. And we've got the computers, so it should not be too burdensome. It's going to be really important for us to really work on our respect for persons, not just in word, but also in deed, and to focus on relationship building. And this is really important for a very big reason that we've talked about. That history of stigma, of marginalization, and of discrimination has created, with very good reason, an atmosphere where we have a whole community that very sensibly has mistrust for the healthcare profession. So we're going to have to do a bit more. And that's going to require for us to build trust and mend those broken bridges and build bridges where we didn't have bridges before with this community. It's going to be important to prioritize comfort for the members of the LGBT community, not for us, right? It's not about how comfortable we are doing the job, right? It's about how comfortable we make the people who come into our healthcare organizations. Confidentiality is going to have to be key, right? Respecting people's rights to control the information about themselves that they want to put out there. And a lot of times people talk about oh, we did the right things and we said the right things. But there are other ways in which we communicate. So think about visual cues and body language, right? How you react when somebody is transgender, right? The sort of questions you ask, the sort of eye contact you make with other members of staff when someone comes in, right? So we need to be really mindful about this. And certainly, we cannot show respect for persons if we don't follow their lead in terms of their preferred pronouns, how they want to be identified, etc. And it's always okay to ask, and ask respectfully if you're in doubt. So I talked a little bit about communication before when I talked about visual cues and body language, but it's going to be really important for healthcare providers to master the language, right? Now, no one's asking anyone to be an expert, right? But at least be knowledgeable enough to know what you do not know and to understand what you do know so that you can seek clarification or ask for help, right? We certainly should recognize and honor gender neutral pronouns. But above all of this, I talked earlier on about healthcare organizations creating structures, etc. We have to develop that culture of accountability. We have to have metrics, right? We have to be able to tell, what is the size of the LGBT community within our larger community, right? We do environmental scans. We talk about that in management, etc. So who's here, right? And what are their needs? And are we meeting those needs? We need to be willing to train our healthcare providers and all the people who work in our healthcare organizations, because you cannot tell who's going to encounter a member of the LGBT community so that they are able to support the mission, right? And if we're going to provide quality care, we need to be able to measure LGBTQ community members' patient satisfaction with the quality of care that they get, with the relationships they have with their healthcare providers, right? And with their general health status. And above all, right, because to err is human, we will make mistakes. And when you are caught out in a mistake, it is okay to say sorry. And my guess is that more often than not, the other person on the other side is going to be really charitable about that. Next slide, please. So I think that this whole issue of what we do with healthcare encounters to make it just so much better for LGBTQ persons goes two ways. So I just talked about the healthcare providers, but as members of the LGBTQ community, there's a responsibility. There is a responsibility to be a savvy consumer of healthcare, or to put it in another way, to be part of your own rescue. Now, what do I mean by that, right? So we need to start moving away and asserting our rights. But to assert those rights, you have to know your rights, right? And you have to take the risk and be a little bit comfortable. Because what we're finding, and I know that the University of Arizona does this, is that there's so much more training and sensitivity awareness that's directed at healthcare providers. And so we're getting, thankfully, more healthcare providers who are aware and who are willing to go that extra mile to meet members of the LGBTQ community. But then there has to be the movement from that other side as well. And so be open, right? The patient-doctor relationship should be a partnership, right? Communication, openness, meeting them halfway and being willing to share information that's pertinent, right? So that the healthcare provider can provide the sort of care that one needs, right? It allows for appropriate discussions, right? So that we're really talking about the issues that we need to be talking about. So sexual health risks, so we're talking breast or prostate cancer, HIV risk, depression, hepatitis, etc. Because we have all of that research data that tells us what to look for. But we need to know that the person who's in front of us is in that category so that those flags can be raised. Do your due diligence, right? Shop with your feet, right? It's it's important to check out healthcare providers. I talked about signals and symbols, right? So if you find a healthcare provider that's affirming of your needs, right? Share that information, right? Share that information with other people so that they can get the sort of support that they need from places that we've been, and that helps to reduce fear. Seek out LGBTQ-friendly healthcare providers, check office policies and practices, and share this information widely. Building community is always really important. We've got to make those connections. It's important to learn about the community resources that are available and to pool that information, give referrals for healthcare that you got that was wonderful, right? And yes, for the ones that were not so wonderful as well, so that people don't go there, and also provide feedback. And that might make those healthcare organizations sit up and pay notice. And advocacy is huge, right? Nobody can sing my song like I can sing my song. And so we need, and I know it's not fair, but this is about our health, right? And that should trump everything. So we need to be able to work to advocate for LGBTQ plus persons' rights with allies and with other people who just work in those areas. And then it's really important to develop and maintain those social connections, because at some point, there's a mutual responsibility in that patient-doctor relationship for us to work together to assure health of populations. Next slide, please. So some things that you can do, and in truth, we should all be doing this, but especially, right, where there is a chance that this might be an important issue. Go with your information, right? Be prepared for that health encounter. This is part of being a savvy consumer of healthcare. List your concerns and prioritize them. You'll be amazed how many people get to see a healthcare provider and forget certain things, right? Plus, it's not like we have an endless supply of time, right? I think it's sort of usually about 7 minutes face time with your healthcare provider. So be prepared. If you have a medication list, take that with you. Certainly, think about changes since your last visit. Take a partner, take a family member or a friend, somebody else with you if you need that, right? Any aids that you might need, take those with you, and then plan to provide an update since your last visit and be open. Now, decision-making is particularly important, right? It is your healthcare, it is your body, it is your life. You should be involved in those decisions. So ask about different treatment options, ask about what your choices are, consider risks and benefits, make them work for this, right? And think about what you value and your circumstances, because that might be different than or unique to you and different than what the healthcare provider might be thinking about. So it's important to flag that. Certainly, we need to be doing a lot more about learning about prevention. Support groups, ask for those. Patient education that's culturally sensitive to your needs. Enlisting family and friends to be helpful, and maintaining control of the appointment. And being willing to seek a second opinion or a third if you need to do that for your health and well-being. Next slide, please. Sensitive subjects are going to have to be discussed, right? So again, remember that I talked about the higher likelihood of drug and alcohol, of smoking, drug and alcohol use. If there are mental health issues, those need to be brought up, right? Abuse problems need to be brought up. Again, so I'm a gerontologist, so a lot of my examples are going to be about old people because that's what I know. But elder mistreatment is an issue, right, within the LGBTQ plus community, as in every other community. So it's not unique. So we need, however, to bring up these things. Think about planning for care, having a living will or a healthcare proxy. That's particularly important, especially if you do not have any of those traditional people in your network, like family members, right? So you want someone who understands your choices, who understands your life, who will make choices for you if you cannot make them for yourself, that will affirm your choices, your personal choices. So share medical and non-medical concerns with them, clarify the issues that are important to you. And like I said before, seek a second opinion or a third or fourth opinion if you need it. Next slide, please. We also need to be mindful that we cannot claim that we know everything that there is to know about the LGBTQ plus communities, right? We need to be open, right? And that's why I like the plus, because the plus signifies that there might be other categories that we're not aware of now, and we're open, right? Because when we come across those people, we really need to meet them where they are. So there are a number of critical issues that we still need to monitor, that we need to evaluate, and that we're going to need to address in the coming decade. So one of those things is particularly important because it drives everything, and that is acquiring a robust body of data on LGBTQ plus Americans. Why is that important? We need to know, for instance, the size of that population, because that's important in terms of determining what services we need, the volume of those services, in terms of determining needs, etc. right? We need to think about the prevention of violence and homicide towards LGBTQ plus community members. Transgender persons, particularly important. I remember earlier on, we had data on suicide rates, right? And just the level of violence against transgender persons. And that's particularly important because if we do not track these numbers and we do not understand these patterns, then we're not going to be able to do anything about it. Next slide, please. Still continuing the issue of what the sort of things that we need to be talking about. I like the fact that we have resiliency up there, right? Because it would be a shame to think that the LGBTQ community is just this pathetic community that needs to be saved all the time, right? There's a lot of resilience in this group, and that's something that we should tap into, and something that other communities can learn from. Because if you think about the history and the facts and the experiences that this community has gone through, then we can see that there's a high level of resiliency and the benefits that that brings to this population. And as healthcare providers, we need to be aware of that and tap into that when we're working with LGBTQ persons. So we need to do a lot more of that. Parenting issues across the life course is another thing that we need to worry about. Older adult health and well-being. We find in later life that many LGBTQ members who came out in their youth are forced to go back into the closet in later life, and that's a travesty of justice, right? So we need to be thinking about those things. We need to continue this exploration of sexual and gender identity among youth, and how do we provide support for them as they go through, as they make these decisions or go through those transitions. We certainly need, for sure, an LGBTQ wellness model, because the other models that we have may not apply, right? So what does that look like? When we talk about wellness for LGBTQ persons, what are the criteria, right? What boxes should we be checking, and how should that be done? And certainly we need to include members of the LGBTQ community in designing this model, rather than standing from the outside and imposing a generic model on them. And we also need to do a whole lot more work on the recognition of transgender health needs as medically necessary. In fact, we need to get to a point where we take off gender dysphoria from the DSM as a mental health condition, right? Same as was done with homosexuality, because that in itself is a barrier to all of the other healthcare solutions that might follow. Next slide, please. So this is a slide that shows a list of mental health resources. What I really would like to say about that is, thankfully, there is so much out there now, right? We need way more, but there are so many different groups that provide all kinds of information and data and resources on LGBTQ community members, whether that's for LGBTQ persons themselves or for people who work with LGBTQ persons. There's no excuse to be information poor, right? We just need to go out there to seek it out and to apply it to improve care.
Wow, Dr. Sokan, my goodness, how lucky are we to have you here speaking upon this crucial issue. So imperative that we have your voice and insight in these incredible topics. So thank you so much, really appreciate it.
Thank you.
So I'd like to introduce Michael again to discuss the All of Us research program before we conclude tonight. But first, I'd love to play a quick little video, and then Michael's going to run through the All of Us research program for us.
In the past, we kind of have not really been focused on, kind of been that invisibilized group.
It does still feel that I'm not visible just due to a lack of knowledge. It's not that transgender people haven't been around for very long. It's just that only recently is the medical community starting to think about us.
As a gay woman, I don't feel that the health industry has enough information.
And so being visible and feeling safe and being listened to should be given and top priority.
I'm really excited for this program to say, hey, no, we're all experiencing these issues. We all need support around these issues.
As a trans person, my experience with the medical community has been frustrating at times, especially like when I attempt to see a doctor for a trans-related medical concern. A lot of times I'm just met with like, we just don't have enough research to understand quite why this is occurring with you.
The lack of data has been a major problem for a number of years. It's really only been in the last 10 years or so that the big health systems, the surveys that go out to people nationwide, have included any questions about sexual orientation, and only a handful of them have any questions about gender identity.
It's just frustrating to be met with like the utter lack of research on people like me because it directly affects my life. If I can contribute to anything that helps change that paradigm, I would like to.
Back in the 1980s when, the AIDS epidemic hit, LGBT people had to like rally for themselves, by themselves. So now that we actually have, the NIH to come in to help us kind of look more closely at our community, it's something that we should definitely take advantage of.
The more that the medical provider and medical community can learn about our experiences, our lives, our families, our struggles, our joys, the better that they can meet our needs.
To have an intentional focus to include a broader community feels good.
All of us is really taking this approach to make it inclusive of as many people as we can.
I think this program is going to be so phenomenally huge because it really is going to hopefully encompass all of us.
And learning about all of us, it totally clicked for me.
We'll have the information from 1 million people, people of color, LGBT people, people from diverse communities to tell us about themselves.
To get their biological information into the database so that there's more information to work with when trying to develop new ways of treating people.
I want to be a part of a program like the All of Us program that collects this hard data to make decisions in the future and help others.
This is a game changer to have a program like this that really is going to look at the nuances of what we experience.
By enrolling in the All of Us research program, it's you're 1 in a million, and your unique story is like a part of this larger narrative that you might see yourself as just being a small person, but when you have that data amongst so many other stories and other people's health data, I think pictures can emerge and that you can actually contribute, have an impact on the future of the health of our community.
I'm really excited to be a part of this initiative and to start bringing awareness to the various issues in our community.
It's really a much broader call to stand up and be counted. All of us being seen will give us hope.
My hope would be that the All of Us research program would just get people to really be aware and understand that by them being proactive and joining, that it helps other people.
Whatever information that you glean from me helps someone like me or anyone else in the future.
Enroll, get involved. in the past.
Okay, Michael's thankfully going to be able to talk to us a little bit about the research program and inform us about what we're doing.
I previously was a clinical research coordinator inpatient for All of Us, so this was kind of my day-to-day. The All of Us research program is a precision medicine study. It's a longitudinal study. We're trying to enroll 1 million or more people. We're currently in the 400,000 to 500,000 range. I believe we just hit 500,000. And we're trying to get people from different races, ethnicities, lifestyles, and backgrounds, and enroll them in a study that is really looking at underserved populations in research and customizing that medicine to them. You can go ahead and go to the next slide, Greg. So this is kind of describing what precision medicine is. It's an emerging approach to disease treatment. We're trying to take people's lifestyle and their genetics and their past medical treatments and correlate all of that so that we can kind of increase the quality of care by decreasing the amount of drugs we give people and knowing what treatments work for people. You can go ahead and go to the next slide. So these are questions that all of us might be able to answer. We look at things like cancer, the biomarker for cancer and preventing chronic pain and stuff like that. These studies are all either being done or will be done. And it's really impactful for these communities that don't have that data now. And like previously, people that were people of color, women, LGBT, there just wasn't that data on them. So now we can kind of customize medicine even more so. You can go ahead and go to the next slide. So the promise for participants, we want to improve health. We want to help people learn about their own health and give them access to their data. Ensuring that every community is included. We're really trying to reach out to everyone and every kind of sector of the country, as is a national program, even though we in Arizona work with the Banner Health System and work for the University of Arizona. And it's a chance to learn about research and kind of be involved in a medical study that most people really wouldn't be involved in previously because it's pretty low commitment and it really does provide a lot of results back. And then you can go ahead and hit next slide. This is the current protocol for All of Us. You'll enroll and do some consents to EHR and then some surveys. These consents are the primary consent that kind of describes the program, EHR, which is your electronic health record, your past medical treatments, so we can correlate them. And then answering those surveys so that we can kind of understand why and how you live your life so that we can correlate those. Then we take some physical measurements and we get your biosamples. We do blood for most people or saliva if you've received chemotherapy in the past 24 hours or you've had a blood transfusion, stuff like that. And then we've only just started doing this in the past year, I believe. We do the wearable data, the Apple Health data and the Fitbit data. And we can actually, I submitted to myself, my Apple Health record goes right to All of Us. And they have access to all of that so that they can kind of get as much data as possible and correlate that all together. And you can go ahead and go to the next slide. So there's 860 research projects being conducted with the data from All of Us as we are kind of accruing that data, and we really want to be the database for these studies. And more studies come out every year with All of Us. So you can go ahead and go to the next one. The LGBTQ plus community specifically is really, really important. Obviously, I think there's definitely a stigma in the LGBT community about healthcare and kind of how we view medicine, how medicine views us. You know, does this provider have my my best values or my healthcare in mind? Once they find out I might not be cisgendered or heterosexual or insert identity here. This is describing the scientific questions being studied. Sexual minorities are underrepresented in cancer survivorship. And then scientific approaches. Sexual minorities face unique stressors and health circumstances that have not been well identified. And we're trying to anticipate findings. The study of sexual minority cancer survivorship has potential to inform clinical practice on how mental health, psychosocial factors, and other healthcare needs affect outcomes. These are transgender health conditions, which are really, really important because although the transgender community isn't the largest community, it's a really, really important one, especially to all of us, because transgender individuals represent a really, really open and welcoming community to scientific research. And I think all of us really has an opportunity to provide them back with the data that they can really use for their healthcare. The scientific questions being studied on this page is little known about the general health of gender diverse communities. We seek to characterize the health and well-being of gender diverse individuals. To characterize the health of gender diverse individuals compared with cisgender individuals, the health conditions and behaviors we will examine include smoking, body size, alcohol use, substance abuse, and the list goes on. The analysis will characterize the health and well-being of gender diverse communities in the US. The research can be used by clinicians and future researchers as targets for prevention and treatment. So basically giving back those biomarker tests to transgender individuals who previously may not have seeked out that level of healthcare, and we also get that data back as well, which helps myself and everyone else in the program. It's really, really important. It's a really important community. It's a really important study being done. And then you can go ahead and go to the next slide, Greg.
Perfect. Thank you, Michael, for that. You know, you spoke on it, but that overview was phenomenal. And you know, I think I'm extremely proud to work for such an incredible organization that promotes such diversity and always strives to lead the way in discussing these crucial issues. And that's why we wanted to put on this webinar this evening. So we're very lucky to have not only incredible panelists with us tonight, but they also were able to answer all the open questions. So if you want to take a look at the Q&A section, there's some incredible dialogue that's going on right now, and really some in-depth questions that our panelists were able to answer. But if you want to, in the next couple minutes, throw a quick question on, we can try to get it in before we have to leave. And I wanted to say, give a pitch for one more little thing coming up here in the next couple weeks on Thursday, June 30th, 6 o'clock. We still haven't determined where our location is, but working on that. And if you fill out the post-webinar survey, we'll be able to get some more information on this. But we want to celebrate Pride Month, obviously, and that's why we're having this webinar with some incredible dialogue and conversation. We're going to be having a movie night, a Rent sing-along, which is going to be so much fun. We'll be able to get the word out to a lot of the folks that were able to attend tonight. And again, you'll be receiving an email tomorrow with this post-webinar survey, which will be able to gain some more info about this great event. Like I said, post-webinar survey. And we just really want to thank you so much for attending. As you can see right on the screen, there are some graphics and some more information to get involved. I know there are a lot of med students on right now, and just want to reiterate to you all to the importance of getting involved in this program, as well as understanding and realizing that anyone has the potential to go onto the research workbench and look at some of the research that's going on, just as Michael was explaining. So I want to thank Dr. Sokan, I want to thank Jimmy Thomason and Michael for your incredible insight on this very important topic. And I want to thank everyone for attending tonight and taking some time out of everyone's busy schedule to be a part of these crucial conversations. So please, we're going to be having more of these, and we'll be able to let everyone know the dates and everything. But thank you again for coming tonight, and appreciate it.